In this short video, we are going to talk about immune dysregulation and autoimmunity. Hi, I'm Christopher. Up to this point, we've talked mostly about how the immune system protects the body. It recognizes threats, responds to pathogens, and helps defend the patient. But sometimes, protection can become friendly fire. That does not mean that the immune system has stopped working. In many immune-mediated diseases, the immune system is very much working. The problem is that it's responding to the wrong target, at the wrong time, or in the wrong tissue. So in this video, we'll focus on 4 ideas: self-tolerance, molecular mimicry, bystander activation, and epitope spreading. The goal is not to memorize fancy terms. The goal is to understand how a protective immune response can become misdirected and tissue damaging. Self-tolerance is the immune system's ability to recognize the body's own cells and tissues as self and avoid attacking them. That is harder than it sounds. The immune system needs to be aggressive enough to fight infection, but controlled enough to avoid attacking normal tissue. There are 2 major checkpoints that we usually talk about: central tolerance and peripheral tolerance. Central tolerance happens during lymphocyte development. For T cells, this occurs mainly in the thymus. For B cells, this occurs mainly in the bone marrow. The idea is that strongly self-reactive cells should be deleted, edited, or redirected before they enter circulation. But central tolerance is not perfect. Some self-reactive lymphocytes can escape into the body. That is where peripheral tolerance comes in. Peripheral tolerance controls mature lymphocytes after they leave the primary lymphoid organs. It helps restrain self-reactive cells through mechanisms like anergy, deletion, and regulatory T cell suppression. Thus, self-tolerance is not one event, it's a layered safety system. When those safety systems fail, the immune system can begin to target the body's own tissues. That failure of tolerance is one of the foundations of autoimmunity and immune-mediated disease. One proposed mechanism for autoimmunity is molecular mimicry. The basic idea is that a pathogen may carry an antigen that resembles a host antigen closely enough that the immune system gets confused. At first, the immune response may be appropriate. The patient encounters a pathogen, and the immune system makes antibodies and activates T cells against that pathogen. But if a part of the pathogen looks similar to a part of the host, those immune responses may cross-react with self-tissue. Ergo, the original response begins as protection against infection, but later it may contribute to immune-mediated injury. A helpful way to think about molecular mimicry is the immune system is not randomly attacking itself, it's responding to something that looks similar enough to the original threat. This concept can explain why immune-mediated diseases appear after an infection has resolved. But we need to be careful. In real patients, molecular mimicry is hard to prove. So we teach it as a proposed mechanism, not as something that we can automatically diagnose from timing alone. The key phrase: pathogen resembles self. Another mechanism is bystander activation. This is different than molecular mimicry. In molecular mimicry, the pathogen resembled self. In bystander activation, the pathogen does not have to resemble self. Instead, the problem is the inflammatory environment. Imagine that there is an infection or tissue injury. Antigen-presenting cells become activated. Cytokines and inflammatory mediators are released. And that local immune environment, it becomes loud and busy and highly activated. In that setting, nearby autoreactive lymphocytes may become activated even though they were not the original target of the immune response. That is why the word bystander is useful. These cells are not necessarily recognizing the original pathogen. They just got caught up in the inflammatory neighborhood. So bystander activation is not about a look-alike antigen. It is about inflammation lowering the threshold for activating nearby reactive cells. This can be clinically important because it helps explain how intense inflammation after infection or tissue injury might contribute to immune-mediated disease. The key phrase: inflammation wakes up nearby autoreactive cells. A third mechanism is epitope spreading. This one is about disease expansion over time. An immune response may begin against one target, but as inflammation continues, tissue damage occurs. That tissue damage can expose additional self-antigens or self-epitopes that were not originally part of the immune response. The immune system may then begin reacting to those additional self-targets. Thus, the autoimmune response broadens. This can help explain why some chronic autoimmune diseases can become more widespread, more complex, and harder to control over time. A helpful way to remember this is molecular mimicry may help explain the spark, bystander activation may help explain inflammatory spillover, and epitope spreading helps explain how the fire expands. Epitope spreading is not usually the first spark. It is more like the immune response widening as tissue damage reveals more targets. The key phrase: the response starts narrow, then broadens. Now let's translate this into client communication. Owners may say something like, "So my pet's immune system is too strong?" This is understandable, but it's not quite right. Immune-mediated disease is not simply an immune system that is too strong. It is better described as an immune system that has become misdirected. The immune system is still doing its job. The problem is that it's aiming at the wrong target. A client-friendly explanation might be, "Your pet's immune system is designed to protect the body from threats. In this disease, the immune system has become misdirected and is treating part of the body as if it were dangerous." That explanation is simple, but it preserves the important mechanism. It also helps owners understand why we may need to investigate triggers, monitor for relapse, and sometimes use medications to reduce or redirect immune activity. The key point: misdirected is more accurate than simply overactive. Let's summarize. First, self-tolerance protects the body from self-reactive immune responses. Central and peripheral tolerance act as layered checkpoints. Second, when tolerance fails, autoreactive lymphocytes may persist and contribute to immune-mediated disease. Third, mechanisms like molecular mimicry, bystander activation, and epitope spreading help us explain how autoimmunity may begin or expand. Molecular mimicry means a pathogen resembles self. Bystander activation means inflammation wakes up nearby autoreactive cells. Epitope spreading means tissue damage exposes additional self-targets and broadens that immune response. Finally, immune-mediated disease is often best explained as misdirected immunity, not as simply an immune system that is too strong. As you continue to study and work through cases, keep asking 3 questions. Why did tolerance fail? What may have triggered the response? And how is that injury being sustained? Thank you for watching. I'm Christopher, and what you understand today helps you protect your patients tomorrow. And I'll see you in the next video.